Hey, so we're most grateful that Dr. Pringsheim is presenting the webinar today. She is a professor at the University of Calgary, Department of Clinical Neurosciences, Psychiatry, Pediatrics and Community Health Sciences, Program Lead of Tourette and Pediatric Movement Disorders, Deputy Director of Clinical Research at the Matheson Center for Mental Health Research and Education, President of the Tourette OCD Alberta Network, and is an evidence-based medicine methodologist of the American Academy of Neurology. Thank you, Dr. Pringsheim.
Good morning, everyone. I'm just going to share my slide. Okay. So I'm going to talk to you this morning about Tourette syndrome in adults. So my objectives are to define the clinical features of tics and Tourette syndrome, to describe the evolution of symptoms over time from childhood to adulthood, and to review the evidence for treatment of tics. So I'm sure many of you are familiar with Tourette syndrome from working with children. There are some unique features of tic disorders in adults, and so that's why I thought it would be helpful this morning to talk about tics in adults. But let's start with a definition of what tics are and what Tourette syndrome is. So tics are movements or vocalizations which are intermittent, often brief. They are repetitive and recurrent. They are non-rhythmic or stereotyped in their appearance, and they're often preceded by premonitory urges or sensation. That's a feeling that one gets before they perform a tic, and often which drives the tic. And tics may be temporarily suppressible. Looking at the DSM-5 criteria for Tourette disorder, it specifies that both multiple motor and one or more vocal tics have been present at some time, though not necessarily at the same time. The symptoms should wax and wane in frequency, but persist, but for more than one year from onset. Onset is before the age of 18, and it cannot be attributable to the physiological effects of a substance or another medical condition. So Tourette syndrome is a pediatric onset persistent tic syndrome characterized by motor and phonic tics. They predominantly affect the craniofacial region. So often the first symptoms that a child will experience will be blinking, nose wrinkling, grimacing, and at the onset, we see more simple tics than complex tics. Tics begin gradually with waxing and waning of symptoms over time. Onset is almost exclusively in childhood, usually before the age of 12, and it must last more than a year. Supportive features include a perceived sense of agency. So people will say, yes, I'm making the movement in response to an urge to perform this movement. They can be suppressible. Having comorbid ADHD and OCD is very common. About 50% of the people we see will qualify for these comorbidities. And having a family history of tics, ADHD, or OCD is also quite common. In terms of its etiology, this is an idiopathic neurodevelopmental condition. So as I just mentioned, neuropsychiatric and neurodevelopmental comorbid conditions are very common and affect about 80% of clinically referred patients will have at least one comorbidity. ADHD and OCD are most common, but we also see a higher than expected rate of anxiety disorders, disruptive behavior disorders, depression, and autism. One of the ways in which we assess tic disorders is with the Yale Global Tic Severity Score. I wanted to describe this to you a little bit at the beginning of the talk because I will refer to the Yale Global Tic Severity Scale score a few times during the talk. So this includes a detailed tic inventory. So here there are different types of simple and complex tics, both motor and phonic, which are listed and which you ask about with reference to the past week. The motor and phonic tics are rated separately on a scale of 0 to 5 across 5 different dimensions. So the number of tics, how frequently they're occurring, how intense they are, meaning how visible or audible they are to other people, their complexity. So are they just simple, or are some of the movements or vocalizations complex? And the amount of interference that occurs with daily life. From this, we derive a total tic severity score, which ranges between 0 and 50, and which is calculated based on the sum of the motor tic score and the phonic tic score. And then there's a separate evaluation of tic-related impairment, which is based on the impact of the tics on the patient's social life, their schoolwork, their family life, and their self-esteem. And this ranges from 0 to 50 by 10-point thresholds. And then the sum of these two scores, the tic severity score and the impairment score, yields a global score out of 100 points. So I want to describe to you the phenomenology of motor tics. We divide motor tics into simple and complex. And simple tics are typically clonic, or that's another word for sort of jerk-like, or tonic, where there's a brief stiffening of a muscle. And these simple tics are sudden, brief, and purposeless. So the most common simple tic would be something like a hard blink. Complex tics appear more purposeful, and they're more sustained in their appearance. So it could be dystonic, which is a more of a prolonged twisting posture. It could be blocking, where someone's unable to perform a specific action. They could be orchestrated bouts of simple tics occurring in rapid succession. And we rarely see complex tics in the absence of simple motor tics. And an important note is that most people with Tourette syndrome have a greater number of simple tics than complex tics, and have more motor tics than vocal tics. This is the prevalence of motor tics by type and location in children. I've got simple tics in blue and complex tics in red. And this graph is really to show you that almost all of the simple motor tics are more common than the complex motor tics. And you can see that the most common simple motor tic in a child is eye blinking, followed by head jerks, eye movements, mouth movements, etc. Only one of the simple tics was less common than some of the complex tics, and that was abdominal tensing. And tics typically follow this rostrocaudal gradation in frequency. So the craniofacial region is going to be the most affected, most commonly affected, and then it progresses down throughout the body. The most common complex tic we see in children is tic-like compulsive behaviors. So these are things such as tapping repetitively, having to even things out. So if I touch, one side of my keyboard, I have to touch the other side of my keyboard. Now, similar to motor tics, we divide vocal tics into simple and complex. So with simple vocal tics, these are sudden, meaningless sounds or noises. So it'd be any noise that you can make in your nasal passages, your mouth, or your throat. Whereas complex phonic tics or complex vocal tics are really anything that involves a language type sound. So this could be the repetition of a syllable, a word, a phrase or statement. It could be changes in the rate, rhythm, or volume of the voice. It could be repeating things that you hear, which we call echolalia. It could be repeating sounds or words that you make yourself. We call that palalia. And when there's the repetition of obscene, inappropriate, or aggressive words or statements, we call that coprolalia. This is the prevalence of vocal tics by type, again, in children with simple tics in blue and complex tics in red. And you can see that by far, the most common vocal tic is repetitive throat clearing, followed by sniffing and coughing. So these are noises that people make in their throat or nasal passages. The most common complex tic was the repetition of syllables or the repetition of things that one hears. I put an arrow over coprolalia, just showing that only 6% of children have coprolalia at their first clinical visit. So when I get the history of tics, I ask about possible exacerbating factors, such as major transitions, being tired, psychosocial stress, or substances which include caffeine or alcohol. Relieving factors are typically engagement in quiet hobbies, doing exercise or playing sports, or playing music or singing alone. During the neurological examination, I will look for intermittent tics. So these are typically stereotyped, meaning they are faithfully reproduced. They look the same nearly every time. They are distractible. So when I engage the patient in the neurological examination, such as following their eye movements, assessing their visual field, checking their coordination, typically tics are less during these parts of the examination. I look for suggestibility during the tic inventory. So when I'm going over the list of possible tics that a person might have, sometimes people will hear the tic and then do the tic. Suppressibility, I can check this through a 1-minute suppression test where we literally just watch the clock and I say, okay, for 1 minute, I want you to try not to do any of your tics. In terms of what the neurobiology of tic disorders is, both neurochemical and neuroimaging studies suggest there's dysfunction within dopaminergic pathways in the brain, although other neurotransmitter systems have been implicated as well, including glutamate, GABA, noradrenaline, and histamine. This is a highly heritable but genetically heterogeneous condition, and environmental factors are felt to play a minor role as well, including autoimmune dysfunction and pre or perinatal adversity. So looking at the epidemiology of Tourette syndrome, we did a meta-analysis of population-based prevalence studies, which found that the worldwide prevalence is 7.7 per 1,000 school-aged children. And this is heavily weighted towards males. So it's about 1 in 100 males and 1 in 400 females. And the prevalence in adolescents and adults has been formally studied in Canada. We did a population-based study of the prevalence of diagnosed Tourette syndrome using data from the Canadian Community Health Survey. And here we found that the prevalence of Tourette syndrome in youth 12 to 17 was 6 per 1,000 in males and 0.48 per 1,000 in females. When we looked in the adults, the prevalence of males decreased substantially to 0.89 per 1,000, but in females stayed about the same. And the prevalence risk ratio decreased. So whereas it was 5.31 in youth, it decreased to 1.93 in adults. So from this, we're really wondering whether in adults, females are more affected or affected differently. So I wanted to go over what happens to symptoms of Tourette syndrome longitudinally if you follow children over time. And this was a prospective study conducted in Denmark at their National Tourette Syndrome Clinic, where they collected data at baseline when children were between the age of 5 and 19, and then in follow-up 6 years later to establish the persistence and severity of tics as well as their comorbidities. So this study was conducted in 2 phases. At the first time, all children who met diagnostic criteria for Tourette syndrome were invited to participate in this study, and 314 out of 376 possible participants decided to enter the study. At the second time point, 227 of these 314 children were re-examined, and they were able to show that there was no difference in the children who decided to participate in the second time point versus those who did not. So their assessments at both time points included the Yale Global Tic Severity Scale score. And they defined someone as having minimal tics if their score was between 1 and 9, having mild tics if their score was between 10 and 19, as having moderate tics if you had a score between 20 and 39, and severe tics if the score was over 40. And, being very familiar with the scale and administering it in thousands of people, I can tell you that I certainly agree with these ratings. The average Yale Global Tic Severity Scale score in a child at our clinic is about 20. So the first assessment occurred at a mean age of 12, and the second assessment occurred 4 to 8 years later at a mean age of 19. And most of these people were seen in person. Only 18% were female, which is expected in a population of patients with Tourette syndrome. And 98% of the participants were Caucasian. So what they found was that between the age of 6 and 26, tics showed an age-related yearly decline of 0.8 points on the Yale Global Tic Severity Scale score. And when they looked at the assessments of children who were over 16 at the second time point, tics were absent in 18%, minimal in 22%, mild in 37%, moderate in 22%, and severe in 1%. So I will often quote these numbers to parents of children saying that, really, the chances of you having moderate or severe tics after the age of 16 is only about 23%. The majority of people will have absent, minimal, or mild tics once they reach adulthood. There's another long-term follow-up study of children into adulthood, which I feel is worth discussing. This was a follow-up of 80 adolescents and adults, 16 to 30, who participated in a long-term follow-up evaluation of a randomized controlled comparison of the comprehensive behavioral intervention for tics and psychoeducation and supportive therapy in childhood. This was a big study that was published in 2010 that really established the efficacy of the comprehensive behavioral intervention for tics in children. So the follow-up occurred about 11 years after treatment, and the mean age at follow-up was almost 23. Again, as expected, 75% of participants were male, and the majority were Caucasian. So the participants in the study had completed an initial baseline assessment of their tic severity and comorbidity as a part of the clinical trial 11 years earlier. There were independent evaluators who performed assessments of their psychiatric diagnoses, their tic severity, and their tic impairment. Their parents had also provided demographic information about their medical history, the parent-rated tic severity, and internalizing and externalizing symptoms on the child behavior checklist. The youth also rated the severity of their premonitory urge and their family functioning. So they were able to include 80 of the original 126 participants in the trial, and they re-administered the Yale Global Tic Severity Scale. And they performed a multiple linear regression with backward elimination to identify important baseline variables which predicted clinician-rated tic severity and tic impairment 11 years later after controlling for treatment. They determined their baseline predictors a priori, and it included sex, their medication status, their tic phenomenology, so their parent-rated tics and their premonitory urge sensation, comorbidity, including their child behavior checklist, internalizing and externalizing totals, and their self-rated family functioning. What they found was that the baseline predictors of tic severity at 11-year follow-up were female sex and having higher parent-reported tic severity in childhood. So if you were female or your tics were more severe in childhood, your tics were more likely to be more severe in adulthood. In terms of tic-related impairment, 11 years later, being female, never having used a stimulant, and having higher parent-reported tic severity and poor family functioning were the most relevant predictors of tic impairment in adulthood. So I want to move on to tic phenomenology in adults. Now, There are very few descriptions of the phenomenology of tics in adult patients. And really, the existing literature, it's really plagued by small samples and retrospective designs. These were 3 studies that I could find that were focused on tic phenomenology in adults. Many of them were published in the 80s and 90s. So it's a bit old, but I thought it was worth looking at. So this study looked at 58 adults with Tourette syndrome, which was diagnosed in childhood. And it was a cross-sectional study with a retrospective assessment of childhood features. Importantly, they found that tics caused minimal to mild impairment in most of the adults that they saw. And there was no one in their group who had extreme disability. Only 26% of the adults that they saw continued to receive medical care for their tics. And the factors that were associated with mild tics in adulthood were mild tics at the worst period in the person's life and mild tics in adolescence. So here, multiple times we're seeing that having milder tics in childhood and adolescence is associated with having milder tics in adulthood. They described the phenomenology in the table. So 91% had motor tics in adulthood, 66% had vocal tics. The majority had multiple motor tics. You can see that a fewer percentage of patients had continuous tics throughout the day, and that the tics for the most part were not inappropriate, bizarre, or obscene. This is another study looking, again, it's a video and chart retrospective longitudinal review comparing children and adults with Tourette syndrome. And they compared 40 children to 31 adults. And what they found really was that tic phenomenology and severity in adults was really similar to children, but that more adults received treatment for their tics than children. And so just looking at the table, I highlighted the things that I thought were important. You can see that more children carried diagnoses of ADHD compared to adults, but more adults carried diagnoses of anxiety or depression compared to children. Fewer children were treated for their tics than adults. And then if we look at the Yale Global Tic Severity Scale score between children and adults, there was really no difference. This was the most recent study I could find looking at phenomenology of tics in adults. This was published in 2009. It was a retrospective review of all patients diagnosed with tics who were older than 19 who presented in the last 5 years. And the majority of them had tic onset in childhood. They compared these adults to 100 children, and their main finding was that adults with tics had more facial tics and more truncal tics. So I want to tell you about my own research on tic disorders in adults. We have a registry of adults with tics, which we've been running since 2021. And it's a collaborative study with the Tourette Syndrome Clinic in Paris. They have the National Tourette Reference Center there. And our purpose of this study is to characterize the relationship between tic severity and tic-related impairment in women compared to men, to describe the phenomenology of tics in adults, to standardize screening methods for comorbid conditions, and to create a source of potential participants for research studies. So we follow these adults prospectively over a 1-year period, and we monitor their tic severity. So we've had 165 people participate so far. About half are male, half are female. The mean age at enrollment is 29 years. And 65% had a primary tic disorder. And what I mean by a primary tic disorder is that they had Tourette syndrome persistent motor tic, or persistent vocal tic disorder. 30% had functional tic-like behaviors. I think many of you have probably heard me speak about functional tic-like behaviors in the past. These are a rapid onset functional neurological disorder that sort of exploded in prevalence during the pandemic. We saw many young people between the age of 12 and 25 who suddenly developed complex tic-like behaviors. And so you can see that there's a substantial proportion of people, of adults, that were affected with functional tic-like behaviors. I'll just tell you, the purpose of this talk wasn't to discuss functional tic-like behaviors, but fortunately, the incidence of new cases of functional tic-like behaviors has really decreased in the past 2 years, and we're seeing fewer and fewer people who are affected by this functional neurological condition. You can see that we had 5 adults who presented with an adult onset tic disorder. These are patients that seem to have Tourette syndrome, but don't follow the age criteria. So they are not able to provide a history of having tics in childhood, so therefore do not meet criteria for Tourette syndrome, but have something very similar. And then we only had 1 person who had a secondary tic disorder, and that was a drug-induced tic disorder. So I'm really going to just focus on the patients with primary tic disorder. So that's 100 patients in our registry. And their mean age of enrollment was 32 and ranged from 17 to 72. A precise age of onset was available for 82 of them. And that was a mean of 8 years, but ranged between 3 and 16. In terms of the sex distribution, 1/3 were female, 2/3 were male. And then looking at their comorbid disorders, 44% qualified for ADHD, 25% for OCD, 34% for depression, 45% for anxiety, and 7% for autism. So I just wanted to highlight the difference in terms of the prevalence of anxiety and depression in adults with Tourette syndrome compared to children. And from our child tic registries, we know that depression, we screen all the children for depression and anxiety disorders, and the prevalence of depression is only 4% in children with Tourette syndrome compared to this 34% in adults. And the prevalence of anxiety disorder is 19% in children compared to 45% in adults. So I think this is a really important difference. And I think one of my take-home messages to you, is to you that, when you see an adult with Tourette syndrome, we really need to be conscious of screening for these important comorbidities, which often greatly affect quality of life, and treating them for these conditions can often improve their tics and overall quality of life. So this is the motor tic phenomenology in our adult sample. And you can see it's pretty much identical to kids. So things really don't change in terms of the distribution of tics when you follow people longitudinally. So the most common motor tic in adults is eye blinking, followed by head jerks, followed by simple mouth movements, shoulder shrugs, etc. The most common complex tics in adults are the tic-like compulsions. So the touching, tapping, evening out was the most common complex tic. So the phenomenology of tics in adults really is not different from the phenomenology of tics in childhood. Looking at the vocal tic phenomenology, again, we see the exact same distribution in that the most common simple vocal tic is throat clearing, followed by sniffing and coughing. The most common complex vocal tic in adults was echolalia, so repeating things that are heard. If we go to coprolalia, it coprolalia is seen in 6% of adults at their first registry visit, which is the exact same number that we got in children. So I wanted to describe the tic severity that we see in adult patients. So the total motor tic score on average is 12, and the total vocal score is 8. Again, this is very typical for motor tics to be more severe than vocal tics in most patients. And the mean total tic score was 20. The mean impairment score was 21. In terms of the treatments that people are taking, the most common treatment for tics in our adult patients was botulinum toxin injections, which were taken by 25%. Botulinum toxin injections work really well for focal tics affecting the face and the neck. And that is the most common area affected in adult patients. Adults like the Botox injections because they don't have to worry about systemic side effects. Many of the drugs that we use cause systemic side effects that tend to be worse in adults than in children. And so for that reason, that's the reason I think that Botox is used most. About 20% of our patients were taking antipsychotics for their tics, and 15% alpha agonists, and 6% topiramate. The comprehensive behavioral intervention was only used by 7% of our patients, and I think this is mostly due to access. As I'll talk to you about in the following slides, there really is very good evidence to support the use of the comprehensive behavioral intervention for tics. However, it's not covered, and it's not a common skill. And with respect to other treatments that patients in our sample took, 30% were taking an SSRI, either for anxiety, depression, or OCD, and 19% were taking a psychostimulant. I just wanted to show you the comparison of symptom severity in males and females, and I feel there are some trends emerging. I think that when our sample size is larger, that maybe some of this could be confirmed. But you can see that there's a trend towards females having slightly higher total tic scores than males, as well as having slightly higher Yale Global Tic Severity impairment scores. These differences are small, but I think that there is a story here. If we look at the GTS qual is the Gilles de la Tourette quality of life scale. You can see that their total score is, females have a higher total scores than males, and the total score, the higher the score, the more your quality of life is impaired. And then there's the visual analog scale. Here, a higher score means your quality of life is better. And again, we see that there is a difference between males and females. The PHQ-9 is what we use to quantify depressive symptoms, and there was a trend towards females having higher scores on the PHQ-9, as well as a trend as females having higher scores on the GAD-7, which is an instrument we use to measure anxiety symptoms. So I wanted to finish with the treatment of tics. I just put these articles, these are the American Academy of Neurology guidelines on the treatment of Tourette syndrome. There's a systematic review and then a practice guideline as well that you can have a look at. The mainstays of treatment include psychoeducation and support. This is really important for patients to really understand the condition, understand its natural history, and what treatments are available if the patient desires treatment. We have evidence to support 2 major behavioral interventions, the comprehensive behavioral intervention for tics and exposure and response prevention. There is evidence as well for a number of medications, including alpha agonists, antipsychotics, topiramate, and botulinum toxin injections. There is also evidence to support the use of deep brain stimulation, but I'm not going to talk about that today since it is only used in a handful of patients per year. So the comprehensive behavioral intervention for tics, also called CBIT for short, is a manualized treatment program consisting of habit reversal therapy, relaxation training, and a functional intervention to assess situations that sustain or worsen tics. There are RCTs in both children and adults demonstrating the efficacy of an 8-session protocol over 10 weeks, as well as a successful open-label study in younger children. Treatment through video conferencing appears to be as effective as face-to-face treatment, and treatment gains are maintained for at least 6 months. There is high confidence in the evidence that CBIT is more effective in reducing tics than supportive psychotherapy, and the effect size is in the moderate range of 0.56, and this is based on 2 Class 1 studies. Exposure and response prevention for tics is really based on the principle that exposure to the premonitory urge that precedes tics without performing the tic can lead to habituation to this urge. So patients are taught to practice tic suppression, and then we gradually provoke the premonitory urge to make tic suppression more challenging. There is a comparative trial of ERP to CBIT suggesting similar efficacy of these interventions. And there's also been some trials of therapist-supported online remote ERP versus psychoeducation, resulting in a significantly greater improvement in tics, although the effect size was small. Looking at antipsychotic medications for tics, there are a number of antipsychotics which have been found to be efficacious for tic disorders, including both first-generation and second-generation antipsychotic medications. There's been a number of trials with moderate or low confidence for these various medications. And looking at other medications for tics, we have evidence for clonidine and guanfacine, which are alpha agonists, topiramate, botulinum toxin injections, as well as cannabis. So I want to give you some practical tips for prescribing medications. So typically, I would begin with an alpha agonist in a child and botulinum toxin injections in adults. The alpha agonists, the extended release formulations are preferable. When using an alpha agonist, one needs to be aware that they take quite some time to work. So they must take them for 2 to 3 months for the full effect to occur. And patients need to be monitored for their blood pressure and their heart rate. The reason I use botulinum toxin in adults is that the tics tend to change in location less in adults compared to kids. Works very well for tics of the face and the neck, and there's really minimal side effects. Second generation antipsychotics are second line. However, I will use them first line if the patient has very severe tics and we want to get control of the tics quickly. Usually with an antipsychotic, there's a noticeable effect within 2 to 3 weeks of reaching the target dose. I typically use aripiprazole if the patient has comorbid OCD, anxiety, or depression. I'll also preferentially use aripiprazole in a female patient. Risperidone, I will use more commonly if the patient has comorbid behavioral problems, because we have more evidence for risperidone in the setting of behavioral concerns. And with second-generation antipsychotics, one needs to monitor for metabolic side effects, hormonal side effects, and drug-induced movement disorders. With respect to the first-generation antipsychotics, haloperidol and pimozide are certainly effective for treating tics, but they are very poorly tolerated. Haloperidol causes a lot of sedation, and with pimozide, you need to monitor the electrocardiogram, the QTC interval, and it does cause significant QTC prolongation. So typically if I use a first-generation antipsychotic, which I really only do in treatment refractory patients, I'll use fluphenazine. And with fluphenazine, you need to monitor for metabolic, hormonal, and drug-induced movement disorders. The first-generation antipsychotics do cause weight gain. It's just not as rapid as the second-generation antipsychotics. I find that topiramate is a useful medication in patients who've become refractory to antipsychotics. It's also a useful medication in overweight patients. And sometimes I will use it in combination with aripiprazole. Cannabis can be helpful in some patients, but the difficulty with cannabis is that you can't take THC and go to work or drive. And really, it's only appropriate in adult patients over the age of 25. And most of the data that we have to support the use of cannabis is specifically for THC. So in summary, tic disorders often improve in adulthood, with less than 25% of patients with tics in childhood reporting moderate or severe tics after the age of 16. Female sex may be a risk factor for tic persistence in adulthood and greater tic-related impairment. Adults with tics have a greater risk of comorbid depression and anxiety than children. And there are many treatment options, including both behavioral therapy and pharmacotherapy. I'd be very happy to take any questions, either through the chat, or if you want to speak your question, I'd be happy to listen.
You'll have to speak tomorrow.
Yeah. Yeah. Are there any questions?
Hi, yes, for your talk. I do have a question about knowing the difference in how to treat some of those complex tics between OCD versus tics, especially when it involves like the symmetry tics in terms of like touching one side and then the other.
Yeah. Yeah. So you mean behaviorally, right? With in terms of using CBIT versus ERP?
Yes.
Yeah. I think most therapists who treat a lot of patients with tic disorders will use a combination of habit reversal therapy and ERP, really whatever works with the patient. And so there really is no preference in terms of, I think it's whatever you're comfortable with and whatever the patient responds to, but I would try both strategies. And that certainly, in Europe, they use a lot of ERP or in combination with habit reversal therapy. And while I don't practice behavioral therapy, I've attended many courses and they typically will use some elements of both. So I don't think you can do it wrong here, right? So you could practice, exposure to the urge and just simple suppression of the tic, like encouraging them. You've got typically with ERP, they've got the clock, the stopwatch going, right? And they're exposing the patient to the urge, and they're just encouraging the patient just, hold it in, suppress. Whereas, with the habit reversal therapy, you'd be trying to engage them in that competing response so that, which is physically incompatible with the tic that they have the urge to perform until the urge starts to dissipate. Does that answer your question?
Yeah, it does. But I guess part of my question was about diagnosis as well when they present with that complex tic, I suppose.
Complex tics versus compulsion.
Yeah, exactly. Yeah. Complex tics versus
Yeah.
OCD.
Yeah. So, I know that not all patients are able to articulate an obsessive thought. But that's when they are able to articulate, yeah, I'm doing this because I'm trying to prevent this dreaded outcome, then you would diagnose a compulsion. When someone says, I need to do it because it feels right, right? It feels just right, or I have that strong urge, then we'd be more likely to call it a tic. But we recognize that the distinction in many cases is sort of academic, right? And that, I have patients where I can't tell and they can't tell if this is tic versus compulsion, but we would use a similar approach. There are patients who we say have Tourettic OCD, where the symptoms are really all on the borderland between tic and compulsion. It's a really common question that we get from doctors, from therapists, in terms of how do you tell the difference? And it's not always obvious. Yeah.
Thank you.
Yeah, no problem. I'll read out some of the chat questions. Can you talk about psychostimulants and tics? So I assume that you're talking about worsening of tics with psychostimulants because it's on all the product monographs that you shouldn't take this drug if you have tics. So I can tell you that I do prescribe a lot of psychostimulants to patients with tic disorders. I tell them that there's about a 20% chance that their tics will be exacerbated. I tell them there's an 80% chance their tics will be either no different or better. And I have these statistics from a research study that was done more than 20 years ago. It was called the treatment of ADHD in children with tics, where they randomized children to 4 groups. So either methylphenidate, clonidine, methylphenidate plus clonidine, or placebo. The rating, the risk of worsening tics was similar in all 4 groups. 20% of tics of children, their tics worsened across treatments, and the remainder of children actually improved. So if you look at the mean tic improvement in children that got methylphenidate, it was actually a statistically significant improvement. So I think with psychostimulants, what you need to do is watch the dose. So you're not going to push the dose to the highest dose in a child who has tics, because then you're going to run the risk of exacerbating their tics. And it's more, I think the conservative strategy is to start with methylphenidate rather than dextroamphetamine. Methylphenidate is not as strong in terms of the pharmacology of the drug. It's less potent than dextroamphetamine. And so typically I always start with methylphenidate. If I see a child who's on dextroamphetamine who reports tic worsening, I suggest that we try methylphenidate instead. I always start, if the treatment target is ADHD, regardless if the child has tics, I start with a psychostimulant because of ease of use and the amount of benefit. The effect size is easily double compared to the alpha agonists. So there's another question here. I hope I answered your question. There's a question, not sure if I missed this, but are the tics measured in time, per minute or per day? If day, is it a 24-hour period? So I'm assuming you're talking about the Yale Global Tic Severity Scale, which we were discussing. And the Yale Global Tic Severity Scale pertains to the last 1 week.